including spine neurology. And I am going to get started today giving a brief talk that's sort of an introduction and overview, and then I'm going to turn things over to my colleagues from different disciplines, also spine doctors. We're really lucky here at Cornell because we have this interdisciplinary spine group that can really reap the benefit of doctors of varying specialties working together on a regular basis to promote really individualized and optimal spine care. So I'm going to get started with some just overview stuff about what the spine is and why it tends to cause problems, and then I'll turn things over to my colleagues who can talk more about what we do about that. So, as an introduction, back and neck pain, and when we talk about the spine, we're talking about the entire spinal column from our neck through our thoracic spine down into our lumbar spine or low back and sacral spine, sort of buttock area. Pain that is from the backbone, from the spine, either whether it's located in the neck or the low back, is exceedingly common. It is something that affects millions and millions of people over the course of their lives, and is a leading cause of functional disability. So, people not being able to work or not being able to have a full quality of life, not able to pursue things that they enjoy, usually on the basis of pain, because pain is really the main issue, but also at times because of neurological problems that occur. We'll go over a little bit of the anatomy and the nerve structures, and are very kind of close with the spine. So in some cases, people can have neurological problems such as numbness, weakness of arms and legs. We'll go over that a little bit. There are sort of, as a basic kind of overview, ultimate summary sentence, is there are a lot of causes for back pain, and because of that there are a lot of treatments, because treatments are really best when they're really focused at the cause. So we're going to go over, my part is here really, what is the spine and why does it cause problems, and then I'll turn it over to my colleagues to talk about the management of these problems and how to keep the spine healthy. The complexity of our spine is really amazing. It is a structure made of a lot of bones and a lot of different tissues that has this sort of dual role to be both at the same time strong, structurally very strong, it's really our core, and also flexible to allow us to move our heads, move our neck. So therein lies its vulnerability, because it has to really sort of enact these two roles that are in some ways opposite. So the spine is made, when we talk about the spine, it's made up of a lot of different types of tissues, so different anatomical types of tissues. Bones, so I'll show you some pictures in a minute, but the vertebral bodies is what they're called, and these are bones that are just stacked, one on top of the other, connected by connective tissue, ligaments, tendons, that kind of thing, and discs, which sit between the bones as shock absorbers. Also, there are nerves that are really closely associated with the spinal cord and the whole spine structure. And then muscles which connect, both small muscles that connect the individual bones as well as longer muscles that really kind of lie along the entire spine. So to sort of just say it again, the key is that this structure has to be very strong, but at the same time it has to be flexible, which is why it has all these kind of component parts. So injury to any of these component parts, the bones, the ligaments, the tendons, the muscles, the nerves, either by themselves or in combination, which is usually the case, is there some kind of combination, will cause pain. Sometimes it will also cause neurological symptoms, numbness, tingling of the arms or legs, but pain is usually the main thing. So to give us kind of a context of the human spine. So the human spine is really our core. It's our central line that connects our head to our tail. Not that we have tails, but other animals, all other vertebrates pretty much have tails. And then also the lateral, our limbs, our right and left sides. It's really our core, our main structural line. And it has a central function in humans and in all vertebrates, kind of two things. One is to be this fulcrum, this central scaffolding upon which our limbs kind of are connected, and that keeps our bodies together and mobile. But there's also a secondary function, which as a neurologist I care about, is that these bones actually house and protect the nervous system. So by connecting the brain, which is in the head up here, the wiring that takes all the nerves down from the brain into the arms and the legs, it allows you to move, to walk, to talk, to swallow, to speak, all of these things. Really, the wiring for this goes through the spinal cord. So these are intimately related functions of the spine. The human spine is unique in its stressors in that we are the only vertebrate that walks on two legs, so the bipedal walk, right? So if you think of any other animal with a spine, they're quadruped, they walk on all fours. Even the higher monkeys, things like chimpanzees and so forth, have the ability to stand on two legs, but they don't really run that way or walk that way. And the reason why that's important is because we live on a planet with gravity. So every step we take, there is this sort of force of gravity. Our bodies weigh something, and so in the quadruped, in the animals, the spine is really like parallel to the ground, and the force of gravity, the stressors are really divided among the limb girdles, the shoulders, the hips, the long big bones of the the femurs, our big leg bones. Sorry, these big bones. That's not true for our case. In our case, it's a column that's really standing. These bones are standing on top of each other as opposed to being in a parallel line. So this is what we call axial loading. That there's this every step we take, there's this pressure down on this spinal cord, on this column, that other animals don't really have. And over time that can cause mechanical stress and problems. So another anatomical slide. When we think of the spine, we really think of it in anatomical segments. And there are four. The cervical spine, which is the neck. The thoracic spine here, which is really the chest, trunk and thorax. And the lumbar spine, which is your low back. And then the sacral coccygeal segments, which are fused together and kind of buttock area and combined with the pelvis and the hips. Of note, sort of each of these segments have some unique characteristics. The cervical spine, which is the neck, which consists of seven bones, seven vertebrae, has to be very, very mobile, right? We can rotate our heads side by side, up and down. We can do a lot with our head, which makes sense because we need to, we rely as animals a lot on our vision, so to direct our head and our vision is a very important function for us evolutionarily. So the neck is very mobile. The thoracic spine is not very mobile. There are 12 of these, and that corresponds to our 12th rib. Sorry, if I touch this. Can you guys hear me okay? Is there too much feedback?
Can they move the mic closer to your mouth?
I can try. Is that better? Maybe?
No.
It's got a longer thing. I think they can push it closer.
Doesn't sound like it's
Well, it's on.
Okay, is that a little bit better?
Yes.
Yeah, it's
Okay.
just too far away.
So where's your the shot?
There you go.
The one that was successful was in the L4 trial, between the L4
And where's that?
one that
Which is this middle part, again connected with ribs, connects to the sternum. So this is a relatively.
put your mouth nearer the mic.
Okay, is this better?
Yes.
Okay. It's a relatively immobile, it's an immobile segment because again, the bones go, have 2 points of connection from the back around to the front, relatively stable. Then the lumbar spine, which is your low back here, is also mobile. We can bend, we can flex, we can kind of, rotate our trunks, and a lot of that movement is from the low back. Also, because it's lower down, this takes the brunt of this axial loading we talked about, because it's really carrying a lot of the weight of the body. In terms of just more skeletal structure, this is just sort of starting from the bone. As we looked at before, this is the column of bones that are really stacked on top of each other. And in between these bones, there is a disc, which is basically like a piece of connective tissue, cartilage structure, which is like a sac filled with gel. Basically, it's got a fibrous outer covering, and then inside is a sort of a gel-like material, and it serves as a shock absorber. So it's kind of like a pillow. So each of these bones, when you're walking or moving, it sort of absorbs the pressure on top of them. And again, this has to do, it's important for us because the lumbar spine in particular gets a lot of weight, a lot of load. So adding on to the bones, you can see here are a bunch of ligaments. This is anterior longitudinal ligament. You have other ligaments, and these are so the vertebrae are stacked on top of each other like joints, basically. But they also have a lot of, they have this connective tissue that's keeping them together. Otherwise, they would slide apart or fall apart. So adding on more layers, this gives you a picture of another cross-section of the bone. And here's the spine. The spinal cord, you can see, is housed by the bone of the spine and flows really down, the whole spinal cord at each level, giving out nerves. You can see on these pictures that there's really a close relationship, a very integral relationship between these hard, bony structures and these nerve roots, which really come out of these like small areas of bone. So this slide adds on, so you sort of, these yellow guys here are the nerve roots coming out from each level. The white stuff are the ligaments. These are the bones. These are the discs in between here. This slide gives us a picture of the muscles, which are many. So you have these small muscles that really connect every level, and then you have long muscles that connect multiple levels of spine, also from the head, actually, from the back of the head all the way down to the spine, and so forth. So really, we have a lot of different types of tissue, all of which are vulnerable in certain cases to injury and which can cause pain. So from a neurological perspective, what is important in terms of the nerves is we talked about the spinal segments, cervical spine, lumbosacral spine, and the thoracic spine. In the cervical spine, the nervous structures that come out on that level supply the arms. So they supply all the muscles of the arms and the hand, allow you to function and use your arms. The lumbar spine, the nerves that come out from there go to innervate to supply the legs. And this is why back problems can sometimes, radiate. So sometimes people can have low back pain that then radiates down a leg or so forth. This is because this is what's called a dermatomal map. And it shows you, so in the green here, this is the cervical spine. So this is the distribution of these nerve roots. So if you have a problem up in here in the cervical spine, in many cases, that pain can radiate into the arm because that's where that nerve ends up. That's where that nerve kind of pathway goes. And similar situation with the low back into the legs. Causes the main, this is really a summary slide. Really, we talked about this, so there's a lot of different parts, a lot of different tissues. They're very, very intimately, closely associated with one another, and really damage to any of them can cause pain. The main kind of mechanisms that we are dealing with in terms of when we're talking about injury or things that actually generate or cause pain, there are really three that we're concerned about. One is inflammation, which is really the body's response to injury, to tissue injury. So that is a healing response. It's the body's way to try to heal injury, but it also is associated with the generation of pain. Another thing that happens with back pain is muscle spasm and cramping or tightening of muscles, and this is something that happens when the muscle itself is damaged, but it also happens when really any other part of the spine is damaged because, well, for two reasons. One, the muscles work very, very closely with the nerves, so if the nerve to the muscle is at all abnormal or affected or injured, the muscle spasms, it gets irritable. And the other thing that muscles do is they try to prevent injury by what we call splinting, so the muscles will spasm and become tight to actually decrease mobility of the spine, trying to kind of protect the spine from movement that might cause more pain or more injury, so it kind of tries to splint kind of by staying very, very stiff, which in a way can maybe prevent more injury, but also can be very painful. Third, in terms of pain mechanisms, is anytime any nerve is touched at all, very, very painful. I mean, there's a reason why they say, touched a nerve, that kind of thing. The nerves do not like any pressure on them at all. Anytime there's any pressure at all, the nerves is going to be very, very, very painful. So we're kind of dealing, and usually in most issues of back pain or back injury or damage, we're dealing with really all three of these things in greater or lesser extents, like greater or lesser degrees, but they're usually all present to some extent. So when we kind of take it a step further and say, well, what causes damage to the spine? Why we talked about these sort of mechanical stresses and just wear and tear. That's really the main one. I mean, trauma, obviously, again, a car accident, a skiing accident, anything that's actually going to structurally hurt the spine is going to cause problems. But the main thing that we deal with are what we call, degenerative changes. None of us really like that word very much because it sounds kind of bad, degenerative, and we're kind of, as we're realizing as we're using functional imaging and MRI more, we realize that like if you start pulling people off the street, even without back pain, starting about age 30, we're going to start seeing some changes in terms of degenerative changes, just wear and tear changes that can occur involving the discs and involving the bones. So it's like a process of like getting gray hair or getting wrinkles. I mean, everybody, if you live and walk, there's going to be some wear and tear. Whether or not it's going to cause a problem to the person individually depends on a number of factors, genetics, as well as what you've done in your life. Have you been a football player? Have you been a horseback rider? Or things that can actually kind of increase the stress on the discs. But here's just kind of a picture you can kind of see. So here we have the disc sitting between the bones. You can see here this kind of, you've lost some space. It's narrow and small. And this is what happens when the sort of gel, it's like a fibrous cushion filled with gel. When that kind of gets flat and degraded, the disc loses its height, it loses its sponginess, it loses its shock absorber ability, and the body's way to react to that is the bone actually grows. So bone is living tissue and it grows along stress lines, and you can get this sort of overgrowth of bone, which is a way that the body is trying to shore itself up and make the structure more strong, which would be great, except for you have all these nerve tissues that are very, very close to this bone, and so when this bone grows, it can cause pressure and problems, and so then you get injury and pain. Another thing that can happen is, so this is a cross-section of the disc. You can get a tear in that fibrous part of the disc, and some of the gel can squeeze out, and that's what we call it. You might have heard of a disc herniation or a slip disc or that kind of thing, and that gel can also push against these close structures. These things, again, are very close to each other, centimeters, millimeters, really small, kind of small distances. So that's sort of the end of my sort of overview about what the spine is. The kind of key point, and I'm going to turn it over to my colleagues, is that there are a lot of different issues that can go wrong with the spine, and to manage these things to the optimal, optimally, it really has to be done individually, because accurate identification of a particular problem in a particular person allows us to treat that specifically on an individualized basis, and people just do a lot better with this. So with that, I guess I'm going to turn it over to Dr. Singh, who will talk about spine health.
Oh, that's fine. Okay. All right, so we're going to change gears a little bit. Dr. Carey very nicely talked about the anatomy of the spine, what the structures are, where the pain generators can be. So I'm going to take it one step before that and see what we can do to prevent spine problems. And if you're someone who suffers from spine problems, what can we offer in the Spine Center to maybe help manage your symptoms a little better? So my background is I'm a physiatrist, which is a physical medicine rehabilitation specialist. I primarily do physical therapy, prescribe physical therapy. We also do some medications and minor interventions. Basically, when patients see me, my job is to educate you on why you have this problem and how we can manage it better and prevent future recurrences. All right, so objectives. First, we're going to talk a lot about posture and mechanics. Just what things I see in the clinic, why I think patients have back pain. And when they walk into the room, I notice certain things about their spine, and I tell them about this. This is how you can prevent bad things from happening in the future. Weight loss is certainly very important, which we'll touch on. Smoking, I don't have to tell you about not smoking. Every doctor on the planet tells every patient to stop smoking. No different from heart disease, lung disease. The spine is very sensitive to cigarette smoke. There's not much blood supply that goes into the spine, so when you smoke, you really close off those very, very small blood vessels that provide nutrition to the spine. So stop smoking is very critical. And then at the end, we'll talk a little bit about exercises. I don't expect you guys to go home and try these exercises, but just think about them. And then if you see one of us in the Spine Center, we can make sure you're doing them properly. All right. So posture. Let's talk about that briefly. So I'm sure at some point in your life, someone, when you were a kid or in grade school or somebody said to you, don't slouch. Stand up straight, don't lean forward, stand up tall. And they probably told you that for good reason, even though they didn't really know it. So the purpose of talking about posture is exactly what Dr. Carey mentioned, was those little discs in the spine. Those discs are the flexible segments, the shock absorbers, the little jelly donuts in between the bones that help you absorb shock and cushion the spine. So if your posture is not ideal, those discs do degenerate. So as physicians, we used to call this degenerative disc disease. We realize that calling it disease is not really ideal. That's like saying getting white hair is a disease. It's just part of the process. It's an age-related wear and tear. So we want to prevent rapid progression. We can't turn back the clock. We can't stop time. But if we can prevent rapid progression, that's where posture really comes in. So you can see from this figure here, you can see my mouse. So leaning back, leaning too forward, kind of hunching your shoulders, all increase the pressure of the disc. We want things to be in good alignment. So ears over shoulders, shoulders over hips, your knees flex slightly, and everything over the middle of your feet. So another way to think about this is head slouching. So if your ears are in line with your shoulders, the bones and the discs of the cervical spine, the neck, kind of distribute those forces evenly. If your head starts going a little bit forward, an inch forward or an inch and a half, you can see the weight's almost tripled. 2 inches forward or 3 inches forward, the weight's almost quadrupled. So this is what, when I walk into clinic and I see patients kind of forward posture, rounded shoulders, and it's not just patients who have pain, it's people who work at a desk, computer workers, finance, people who answer the phone, anyone, gradually their head starts going forward, their shoulders start going rounded, and I stress it's very important to correct that behavior. So that's something we can see in clinic. So even when you're sitting, it's important to maintain good lumbar support. So here this patient's trying to overcorrect, so that's also not great for the spine elements in the back. Slouching again, putting a lot of pressure on the discs. Good postures with a little lumbar support, head, ears in line with the shoulder, so again, that alignment we want to see. Last picture about posture. Good posture here, that curve of the spine is maintained. Bad posture probably due to not an ideal chair. So we do a lot of ergonomic evaluation in our office. Patients come in saying, my desk isn't ideal. Is the chair I'm sitting on not appropriate? So we have ways to actually go to their home or their workstation and see and adjust things accordingly based on their body size and body habitus. But chair and lumbar support is very important. Lifting things, we all have things to do in our daily lives, moving or carrying things from one place to another. So the way you do that is very, very important. A lot of us think just bend over, pick it up, bend your knees, but this puts a lot of stress on the back here. So I actually demonstrate to patients how to lift things in the office. So get very close to the object, keep your back straight, and use your legs. That just protects your back for anything you're doing when you're moving or carrying things. Same thing over here. So don't bend and lift at the waist, use your legs. Get really close to the object. Even when you're lifting your kids or your grandkids or any family members, don't lift them far. Bring them close to your body. That takes the stress off the lumbar spine. Weight loss. So we talked about the pressures of the disc on the spine. So every pound of extra weight is about 7 to 10 pounds on each disc. So some patients walk around with 5, 10 extra pounds. That's about 70 extra pounds on the spine with every motion. So I stress weight loss, I stress core stability, working on the abs, the obliques, the low back muscles, but weight is very important. Men actually have a little bit worse than women because men hold weight pretty high up, whereas women tend to distribute a little bit better, so they're protected that way. But still, weight loss is very important, something we talk about. Same kind of thing. Apple shape versus pear shape, that's what we kind of say. Carrying things, I see many patients come to the office with 6 bags, a gym bag, a backpack, a purse, a bag with shoes, a bag with a sandwich. I say let's try to consolidate this and try to take only what you need. Because again, everything you're carrying on your spine that you don't really need is extra weight on your spine. Kids are no strangers to back problems. I remember in grade school, putting only 1 strap on your shoulder was cool, and you go to college and 2 straps is cool again. So I tell all the kids, or if kids come with the parents in the clinic, 2 straps. Distribute the force of the backpack evenly among the spine. Don't sag it. If you sag it, again, you tend to hunch forward. Keep the backpack up. So this is just for kids or anyone who carries a backpack. Here's a patient's I see, a huge bag with almost nothing in it, or tons of stuff you don't need, lipstick and cell phones and eyeglasses and shoes. So if you're going to take a bag, I recommend taking only what you need. If you do have to take a lot, try a crossbody bag. So again, it distributes the weight of the force evenly, so not just one side. If you're really, really into fashion and you have to pick one side, balance it. One side on your way out, the other side on your way home, just so the forces are balanced evenly. Smoking, we already talked about this, so there's a picture of what smoking can do to the bones. So here's a healthy bone, a lot of nice solid calcium in there. After smoking, it degrades that. This leads to osteoporosis, spine fractures. We want to avoid this at all costs. Not only are the bones vulnerable, these little discs. So see how juicy this disc is in the middle? With smoking, it's no longer that way. So those are the shock absorbers. So let's talk briefly about exercise. Exercise, like we say, is very, very important in preventing spine problems. But I can't just tell you go home and exercise. I have to give you some type of focused program. So based on your symptoms, based on how you present in clinic, we focus the exercise program to your specific problem. So just like this gentleman here, the coach says, I don't know what to tell you, Mr. Miller, but something has definitely gone wrong with your program. So it's specific exercise focused on what your problem is. Stretching is good, but you have to be careful with it. If you do too much stretching, toe touching, bending forward, again, you're putting a lot of stress on the disc. So we want to do that in a safe manner. So you can't overstretch your hamstrings. Well, flexibility is good, like I said, but you want to do it safely. Core stability. This is the abs in the front, the abdominal muscles, the love handles on the side, and our lower back muscles. These together make a core. Think of it as a cylinder. So sit-ups aren't ideal. We grew up saying sit up, sit up, sit up for the abs. That's probably not the best way to work on core strengthening. Crunches are a little bit safer. If you are going to stretch your hamstrings, I'd recommend doing it flat lying on your back rather than bending forward. It just keeps your spine healthy. Avoid leg lifts. This, again, puts a lot of pressure on your lower back. There are safe ways to do this, but it's not really necessary when there are better exercises, which I'll show you. Press-ups can help. Again, if your problem is a disc herniation and you have sciatica, sometimes press-ups can help. If you have primarily back pain, then this may not be the exercise for you. So again, the exercise program has to be tailored to your symptoms. Bird dog or quadruped position. It's working all the muscles along the spine. The lower leg, the buttock, the lower back. So again, another possible exercise to consider. Bridging, a very safe exercise, keeps everything in line. And then the exercises that I tend to give patients, mostly core stability. So this is a way to work on the lower abs. The patient is flat, and then flat here as well. So they're not putting any pressure on their lumbar spine, thoracic spine. It's just on the core. So this is for the front abs. Side abs, the love handles, these are the toughest things that we all tend to work on. Again, you have to do this safely, make sure your shoulders and your upper body can handle it, but there are safe ways to do this. And then glute bridges is the last thing. So patients flat here, they pop up and they work on their lower back. So all these structures are the core. They offload that disc, so that degeneration that we talked about earlier, we can minimize that, we can slow down the progression. We can't stop it, of course, but if we can slow down the progression, that's the goal. So again, I saw this young lady taking pictures over here of each of the exercises, so be safe with it. I want you to do these exercises, but make sure we do it safely. Don't try these at home without some consultation with one of us or a spine specialist. Again, so we can't reverse time, but we can help prevent progression. Our goal is to make everyone strong, like this young lady, 81-year-old weightlifter, surfing, water sports, if you like to do that kind of stuff, swimming, 73 years old. These are all real people. I didn't make them up, I promise. And weightlifting. So if you do these things, keep your body healthy, smoking cessation, eating right, we can avoid looking like this. All right. So I'm going to give it over to Dr. Mehta.
I'm Dr. Mehta. Actually, I'm not. I'm Dr. Hartl, but I'm on call and actually I have a case. I have to go back to the operating room. So Dr. Mehta was very kind to offer that I would give my presentation now, and then he will finish up with his presentation. So I will just tell you a little bit about surgery, and So anybody has had surgery, spine surgery? Nobody. Okay. Anybody had injections? Any kind of spinal epidural injections, or anybody with back pain tonight? Okay. So you came to the right place. So I want to shed a little bit of light on what the role really is for surgery in patients with back and neck pain. And I will go through a number of slides here. And some of these are specific in terms of surgical procedures. Others are really more general, but I'll try to give you a good overview. You know, as a surgeon, when we look at patients with back and neck pain, what makes us think that maybe a surgical procedure is indicated? And on the other hand, when do we think that surgery should really not be considered because it may be over-treating or maybe the wrong treatment? So the role of surgery really is determined by what type of symptoms you have and what you have done in terms of treatment before, and then also what the diagnostic studies show. And that's where MRI scans come in, CT scans, and so forth. We want to talk a little bit about how we treat this surgically, what type of surgical procedures we can pick. And then we'll talk a little bit about less invasive surgery. We here at Cornell really pride ourselves that we try to be very, very conservative when it comes to surgery and really only operate if everything else has failed, unless it's an emergency like my case that I'm going to do in a few minutes. And if we do surgery, then we try to pick an operation that's the least invasive and least disruptive procedure that hopefully will give our patients the best possible outcome and the fastest recovery. Now, you've heard a lot about back pain. You know that most of us at some point in our lives have back pain, as the overall population also experiences. And there's a tremendous economic burden with back pain, and it can lead to a lot of suffering, as a lot of you know, as I just found out. This is an MRI scan of a patient with back pain. You can see this is the lumbar spine that we're looking at. These are the bones, the discs, and you can see at the lower part of the lumbar spine, this disc is very collapsed. So we know, for example, that this could be one of the signs of degenerative disc disease that can cause a lot of back pain. So degenerative disc disease is something that we see very frequently. Disc herniations, that's a patient with a herniated disc here, a disc that's pushing on the nerves, that's causing radicular sciatica type pain. And patients can have spinal stenosis, they can have deformities of the spine. And all of these pathologies potentially are targets for surgical treatment. But again, it depends really on the severity of the pain that you have. Do you have any kind of neurological deficit? And what have you tried in terms of other treatments? And then there's certain things that we look at in patients with back pain that are really important to make sure that we're not missing something that may indicate something more severe, not just arthritis or degeneration, but for example, people can develop back pain because they have a tumor, cancer. So those are red flags, and that's really very important that we look into that and pick that up very quickly before we rush to any kind of other treatment that may miss the real underlying diagnosis. This is a cut from an anatomy book through the lumbar spine, and it shows you a normal lumbar spine with normal bones, normal discs. These are the spinal nerves traveling down. And then here, in somebody who has severe degeneration, you can see that the discs are collapsed, the bones are deformed. Those are very typical signs of arthritis that we see that can be associated with back pain, but they're not always. You can have the most terrible looking MRI scan of your back, and you may be completely pain-free. And that is the challenge that all of us face constantly, trying to determine, does that MRI scan, does that terrible looking MRI scan really account for the patient's pain? And that's really where the art comes into play. It's not only science, there's a lot of art involved. I'm not going to talk through about a lot of these basic kind of facts that you probably heard about already. So I want to go a little bit more into what the role is of surgery. And you talked about exercise that you can do. the spine center. In the spine center, what we really think is important that we look at pathologies from all different angles. And not only, we would only have you see the surgeon, but if necessary, you will also see the neurologist, the physiatrist, pain management doctor. And and I always felt that was very important because very, very few patients end up needing surgery. For 95% of patients with back and neck pain, and that's my mentor who I trained with in Phoenix, and he would not like the slide because for 95% of patients, there's no surgical solution. And not necessarily that they don't do well, the opposite is true. Most patients actually get better without surgery. And I only want to stress that to kind of point out that that we're aware of that, and that's why we want to be very conservative before we suggest any type of surgical procedure. So for 100 patients with back pain, maybe 10, 15 end up requiring some kind of procedure, for example, an injection with Dr. Singh or Dr. Mehta, and only about 2 patients actually need to go to the operating room for surgery. So, and the challenge and really the important thing is to pick the right patients that really would benefit theoretically from surgery. So what happens if non-operative treatment fails? Well, then you take a patient to the operating room, and then from my perspective, who are the patients who potentially will do well with surgery? There are some patients, when we see patients in the office, I think we can tell within a few minutes, without really engaging in major examination or conversation with the patient, just by looking at the MRI scan, just knowing a few basic facts about the pain, I think I can say in about 95% of cases, is that a patient who's actually going to benefit from surgery? And why is that? Well, that is because we know with surgery, we're very good at treating arm and leg pain, for example. Patients who come and have pain that's, sciatica type pain that's shooting down the leg or shooting down the arms, and they have a herniated disc that causes that pain, those are our happiest surgical patients. Whereas patients who present just with neck pain or back pain without any shooting pain up or down the leg, those are patients who are very, very difficult to treat with surgery, and they may really benefit much more from physical therapy, maybe pain management. So, and then there are patients who come in with neurological deficits, with partial paralysis, myelopathy, because they have spinal cord compression. And those are patients who obviously will require surgery and probably require urgently, maybe even emergently, because they've got spinal cord compression. So those are the 3 large groups of patients: neck, back pain, radicular pain, and myelopathy. And I don't want to overburden you with medical terms, but I thought that may be important for you also to understand, because I see patients all the time who are disappointed when I tell them that I can't help them as a surgeon. And the reason is, again, patients with pure back or pure neck pain don't do very well with surgery, typically. Sometimes they do, but the majority will not. So the factors, what favors surgical treatment? If what you tell me in clinic and what I see on the MRI scan, if that all kind of fits together, and if the MRI findings, for example, explain what your pain and what your weakness looks like when I examine you. If you've got a herniated disc that's pushing on the nerve and you tell me you've got pain in the distribution of that nerve, that's usually a very good sign that surgical decompression at that particular level of that particular disc herniation, for example, is probably going to be successful, and you'll be very happy. If that doesn't correlate, if there's no good correlation between what the MRI scan tells us and what your symptoms are, then surgery, generally speaking, is probably not a good idea. If somebody has a neurological deficit, if they come in with a foot drop, if you have a foot drop and a large herniated disc in the lumbar spine, you probably need an operation, and chances are you're going to do very well from that surgery. If you have a foot drop on the right side and the disc herniation is on the left side, though, that's a problem. I've seen that also. That can happen, and then you probably shouldn't operate. And then there are obviously conditions, again, where there are emergency underlying, severe spinal cord compression, for example, where patients absolutely need surgery very, very quickly. And I think I want to just show you one case here And this is really a case that comes, that we see on a very, very regular basis all the time. This middle-aged gentleman with 2 months of pain radiating into the right foot, sciatica pain radiating into the right leg, into the right foot. He's tried physical therapy and medication, no back pain, no weakness, so no neurological deficit, basically just severe sciatica type pain and no red flags. So we're looking into other things, does he have a severe infection, cancer, and so forth. None of that is the case. He really has just sciatica from a herniated disc. Now, if you look at this MRI scan, do you think this MRI scan is normal or abnormal? No idea, right? So this is actually normal. You can see the spinal nerves traveling down in the spinal canal. That's the spinal fluid here. Now, if you look at this MRI scan here, you see that that's abnormal, right? Everybody can see that. The difference is a large black herniated disc that's pushing on the nerve on this side here, and that's what's causing the pain in that patient's leg and foot. Now, if that pain corresponds to what we know from the anatomy book that pain is supposed to look like, then that patient will do very, very well with a discectomy. And the discectomy is an operation where we go in and we, under the microscope, we identify the nerve that's being compressed by that disc herniation, and we remove that part of the disc that's squeezing that nerve here. You can see that here. And we do that under the microscope with microsurgery, minimally invasive, and those are our happiest patients.
Wow.
Again, that's the situation where you've got a focal finding, pain shooting down the leg, and the patient has tried everything else, and we can see on the MRI scan exactly what's causing that particular pain. That patient didn't have back pain, but leg pain. And those are really the most successful operations that we're confronted with. So I think I'm not going to go much further than this, but I basically just wanted to kind of give you a very, very brief overview over how, from a surgeon's perspective, how we try to evaluate and assess the situation when you come to see us or me. Again, don't be disappointed if you hear that, surgeon cannot help you, which happens. It's probably a good thing. But if I tell you that we can help you, then I think you should also be happy because because obviously you've been in a lot of pain. But there are certain situations where, for example, chronic back pain and so forth, where surgery is not always the answer. However, for those patients, again, who have herniated discs, with pain shooting down the arm or shooting down the leg, with lumbar spinal stenosis, I didn't show you lumbar spinal stenosis, but that's one of the most successful conditions that we can treat, and we can treat that also with minimally invasive surgery. Spondylolisthesis, which can cause lumbar spinal stenosis in the lumbar spine, those are conditions that we can treat very, very effectively. And there are a lot of less invasive and minimally invasive ways out there where you stay in the hospital maybe one night, you go home if you want, you go home the next day, and generally speaking, patients do extremely well. Any questions or?
Sorry.
Yes.
Just in case you have to leave, what is the neuroplasty procedures for neuroplasty?
And neuroplasty is a procedure where there's an attempt to kind of restore the function of the nerve. In what context? For what problem? It's a very general term.
Pain in the back and shooting down the leg. 2 previous surgery failed, and neurosurgeon suggested neuroplasty. Never heard of it, actually.
Yeah, to be honest, I haven't heard about that either in that context. You guys know neuroplasty? Maybe something to look into, but I wouldn't know exactly. It's a very general term, and it's really, yeah, please.
What's the downside of the microscopic surgery that you would do? Go ahead.
The downside?
Yeah, I mean, do you ever have any, for instance, paralysis, anything that really goes wrong?
Yeah, I always tell patients, obviously, you gotta tell patients that there's a very, very small risk of nerve injury and so forth. Extremely rare. Extremely rare because we see exactly what we're doing under the microscope. In procedures that are a little bit more extensive, we actually monitor the function of the spinal nerve. So as soon as we get close to the nerve, there's a signal that goes off, and we're aware and we're careful. Extremely rare, but obviously, things can happen, but it's
So we're talking about like
extremely rare.
1% kind of
It's
thing?
about, for that operation that I talked about, it's less than 1%. It's maybe 0.01%. I'm not sure if I'm supposed to ask questions now, or like, give.
It's up to you, but I think that we were gonna do it at the end.
Yeah, I think
Well-
we're gonna do it at the end, maybe one more, I think you asked it.
I was wondering whether there was an
Except
age
we're gonna
limit
lose him.
or you should not have the operation.
What,
Age limit.
there's no particular age limit. We operate on patients who are in the 90s, I've operated on patients who are 100 years old. It depends on, it really depends on the biological, how you function. And nowadays, things are really very different from what it was like, 10, 20 years ago. The age per se is not a problem, as long as your heart and everything is fine. I'm going to hand over to Dr. Mehta because, I don't want to take this time. And thank you.
Thanks for sticking around, and I promise that it won't be too long. I think I see some familiar faces from talks that I've given here before, so thanks for coming back. And for those...
Can't hear you.
sorry about that. How about now?
Yeah.
Yes. Okay. So I wanted to say I see some familiar faces here, so I'm glad, and I say welcome back to our lecture series here. So we are kind of going back in time a little bit. We talked about the anatomy. We talked about some basic exercises. We jumped ahead to surgery, and now I'm going to take you back one step and what do we do before we go to surgery, or how can we avoid it potentially? So in the algorithm, we're talking about rehabilitation and exercise, lifestyle changes. I'll talk a little bit about some questions that come up all the time in clinic about alternative medicine, complementary medicine, medications that people can try, and various procedures. And then surgery will be the last option that Dr. Hartl just kindly talked about. So really, we've come full circle. Once upon a time, we started out with eating a root, and then we started religious treatment, moved on to elixirs, then to snake oil, pills, injections, and now we're going back to complementary medicine and roots. So 83 million people used it last year around this country. And it's very common for back pain, neck pain, arthritis. These things have been used for other conditions as well, but we're going to focus on what we know for back pain here. So what does that entail? Chiropractic medicine, massage therapies commonly used, vitamin and herbal and mineral supplements have had some various roles. Although the evidence on this is still kind of compiling, we don't know for a fact yet. There was a very big study in New England Journal of Medicine this past year about the fact that many of these vitamins are not useful. So that refutes a lot of things that we've been said. But in that there is a flip argument in that if your diet isn't quite up to what it should be, there is a role for vitamin therapy to supplement. Prayer. Well, my mother is a very religious woman, and she believes that prayer will solve her back pain issues. She refuses to come see me. Naturopathy, aromatherapy, acupuncture, meditation, all of these things in the right context have helped people. That also means that there is a power of belief in this too, just like you believe in potential therapy that we recommend as well. Hypnotherapy, shiatsu, chelation, again, less than 10% of the population use that, but there has been some evidence for it. So complementary and alternative medicine, for the most part, involves acupuncture, massage, and spinal manipulation. May be useful in low back pain. What do we offer here at Weill Cornell? We offer acupuncture, physical therapy that has some component of massage in it and manipulation. We also offer cognitive behavioral therapy. We know that pain can lead to all sorts of anxiety and depression if it lasts long enough, or that if we have other troubles in our life and leading to depression, it can make our pain worse. So it's really a question of chicken or the egg, which one comes first, but we know that both go hand in hand. And therefore, over the past few years, we've really developed a program, and that in addition to seeing the specialist that you've met today, we have a psychologist that really works on mind, body, and trying to help you get coping mechanisms for pain, even if it's not getting better through traditional treatment. Exercise therapy we've talked about, and then also using yoga. Acupuncture is really just an ancient Chinese practice using the power of needles on certain channels known as qi, and we're using that energy flow to treat various conditions. It can treat surgical conditions, it can treat back pain issues. Treatment that we have, one of my partners is offering that, Dr. Joza upstairs. She basically takes about 20 to 40 minutes per session, probably 40 minutes the first time around. You may need a few sessions. It really is kind of a individualized and tailored approach. In terms of what they do, they put needles in certain channels or certain areas. They also put it in with sometimes electrical stimulation along with it. They may twist these needles, they may apply heat in certain areas. So again, there's no standard therapy for each person. It's really kind of individualized for that. TENS, or transcutaneous electrical stimulation, is a device that's about $80, and I've seen them even on the in-flight duty-free magazines these days, so it's getting pretty common out there. Many of you who have had physical therapy may have seen this device in the therapist's office. Basically, there are stickers or electrodes that are placed on your back, and then they turn on an electrical current at a very, very mild setting, and the idea is that it contracts the muscle and releases it much faster than you can do so on your own. And if there is a form of muscle spasm, it can release that. Or there's a principle called gate theory. Gate theory is, for real simple terms, if you have a pleasant sensation coming in at the same time as a painful sensation, and they meet at the gate, more often than not, the pleasant sensation will get preference to go in, and your brain interprets that. So for example, if you were to bang your elbow on this table here, and you start rubbing it, we know that that hasn't really helped or treat what's causing that pain. But that pleasant sensation, that soothing sensation, will make you actually feel like the pain is getting better. And so electrical stimulation works on that principle. It can be placed on the skin, or a little bit later in the talk I'll talk about implantable versions of that. It also has been seen to release endorphins, which is our body's natural pain reliever. So we know that this has worked. Because it's so common now, the device is actually pretty cheap. Again, I told you probably about $80 to buy one on your own. Again, we would use it first in the office or in the therapist's office to decide if that's something of use. Again, heat and cold therapies have been used in the past, although there's no real evidence to decide which one is preferential. In my own personal belief, if it was a warm summer day, putting heat on top of a hot day, it really doesn't seem very pleasant. So for common sense reasons, I use cold in the summer, heat in the winter. These are very, very extensive list of various vitamins and supplements that are out there that have been more commonly associated for pain relieving things. Again, these are things that you would need to discuss with your doctor about what's most appropriate for a particular condition that you're suffering from. Probably the most common one that I've seen used is turmeric. Being of Indian descent, this is in diet that we have almost every day. Sometimes it doesn't taste that good in certain foods, but it takes probably a pretty decent amount to get it. Now, you can go to GNC and buy it, or you can actually go to your Indian grocery store and buy it for like pennies on the dollar. So, supermarkets now actually, yeah, you're right, Whole Foods and so forth have it. 5 years ago, you probably wouldn't have found it as commonly.
Dr. was showing how to make a turmeric tea today.
Who was?
Dr. Oz.
Oh, Dr. Oz. Well, look at him. Yeah.
Tea.
Turmeric tea. My mother used to make turmeric milk. It didn't taste very good, but it was good for colds and such. Again, vitamins, controversial about whether they're appropriate if you have a good balanced diet, which means that you're probably getting them naturally already. So let's shift gears a little bit and talk about medications. Well, real basic is the anti-inflammatories, also known as NSAIDs. NSAID stands for non-steroid anti-inflammatory drugs. Those are the Advil, the ibuprofen, naproxen, Aleve. There's probably about 15 different ones on the market. There are prescription strength ones like that are once a day, twice a day, or there's the every 6 hours as ibuprofen may be. They're effective. They work well. The thing to remember is that when you use them, you have to use them with caution. You have to take it with food, and you have to make sure that your doctor knows that you're taking it at a higher dose if you're taking it over the counter, or if you're getting a prescription strength one that you don't have any other risk factors, like a history of bleeding, a history of prior gastric ulcers, history of a stroke, history of a heart attack. Okay? Tylenol is also effective. As long as you don't have liver conditions, it can be very useful, especially for patients that can't take the anti-inflammatories that we talked about. Steroids can be given by mouth. We'll talk a little bit about the injectable form of it in a moment. Oftentimes, when patients come to me for a newer condition, I recommend a short course of steroid by mouth known as a Medrol dose pack. Very simple to take, a stronger anti-inflammatory than the NSAIDs. Narcotic or opioid painkillers. I used to put the word opioid because that's actually the proper term, but most people didn't understand what I was trying to say, so I used narcotic. Narcotics has a bad connotation. Pain medications like that are strong. They need to be used appropriately. They have to be very well guarded and safe in your home, and they come with their risks. So really, you have to have a proper supervision on how you're going to use it. I'd say out of 30 patients that we see in a day, only about 1 or 2 are actually going to walk out with a prescription for that. So again, it's very limited use, and when you use it, it really should be for a finite amount of time. It should be a discussion with your doctor as to when am I going to come off of this, because this is not meant to be a lifetime worth of medication. Neuropathic pain medications, a little bit different than our talk today about back pain. Neuropathic pain means specific pain to the nerve. There are medications that you probably see on TV, such as Lyrica and Cymbalta, that are used for that. Sometimes they can help in various pain conditions involving back pain. Again, have to be tailored to what your condition is, and also have their own list of side effects, mainly the biggest one being drowsiness. Antidepressants have been shown to be effective in back pain. Cymbalta, again, is the one that comes to mind the most. And then topical creams have really become more popular as of late because they don't go into the body. They stay kind of local to where the pain is. They work for various conditions. Sometimes they're not quite paid for by insurance companies, so they can be a little bit expensive. But the nice thing about them is that they're unique to you. They're made for you. The ingredients are chosen by your doctor to be used for you. So what if you need a procedure? You visited a physician and they tell you you need an injection or so forth. So a common question is, why should we come here? I can go to my doctor who has it in his office or whatever it may be. There are many qualified physicians in New York. I think there's probably about 10 doctors that do these procedures all within a 10-block radius of this hospital. And then, so again, there's a lot of us doing these, but you make sure you know the credentials of the doctor, make sure that they've been trained, they're board certified. A pain fellowship is important for that. And then can they manage any complications if that were to happen? So that's important to know. Epidural steroid injections are probably the most common procedures that we do. This involves placing the steroid directly into the area that's causing the pain. It's done under X-ray guidance because that's how we know we're precise. That's how we avoid risks such as injecting into a blood vessel or injecting into the spinal fluid. It has anti-inflammatory effect on the nerve roots itself, but it's not a curative treatment in that it's not necessarily treating the underlying cause as what Dr. Hartl mentioned, maybe the disc hitting a nerve or such. But many times the pain does resolve on its own in terms of healing the disc. We just don't want you to have to wait that long. So the steroids can really speed up the recovery process and get you into physical therapy sooner than you would have without it. Again, the average time relief is about 3 to 6 months. You can have safely these injections about 3 to 4 times a year if you need it, but it's a bell curve on how much it can help you in terms of time. If you have severe spinal stenosis and you're pretty much at the point of having surgery, that injection may only work a few days to weeks. If you are young and it's your first onset of a herniated disc, it may last you forever. You could have years of relief from it. So again, it's a broad spectrum that this treatment can work for. Facet joints are the joints that help us bend in terms of our spine. And these, just like our knees and hips and shoulders, can develop arthritis over time. Fortunately, we know that there are tiny nerves that come off of the spinal nerve roots that go to these joints that aren't doing anything other than providing sensation to that joint. So we can take advantage of that and potentially quiet those nerves down without affecting our strength or our being able to walk and so forth. This is mainly for what we call axial back pain, or pain that's really limited to the back, maybe going into the buttocks, but really won't be the pain that is like sciatica. This comes as a procedure that is a two-part process. First, we would inject some Novocaine around the area where the nerve is and see how you fare with that over the next day. And if you make pretty good progress, we would then move on to something called a radiofrequency ablation, where we can use electrocautery to quiet that nerve down up to a year without the use of steroid and so forth. And it's a pretty effective procedure. All these procedures that I've mentioned today are basically covered by insurance, no matter which insurance that you have. So in conclusion, even just to kind of conclude for the rest of the group too, that our treatments are multimodal, meaning that there are various treatments. No one thing is going to completely cure your pain. So that's why you have a team approach here, where each person is kind of providing a part of your relief. Rehabilitation, exercise, lifestyle changes, as you've heard today, can help in prevention and recovery. Alternative medicine, complementary medicine has a role that's still developing, but we are using it more and more. And medication and interventional procedures can be beneficial when done appropriately and for the right cause. So that's what I have to talk about, and I think now would be a good time to have the rest of the group come up so you can ask questions of all of us. Okay? So I'll invite